Good evening, everybody. I'm delighted to say that we have our November Unspeakable Bits, and we have a very special guest today with Dr. Hugh Kearney. And as usual, we have our host, Trevis Gleason. Just to let people know that you'll see down below the screen there is a Q&A section. So if you have any questions, please put questions into the Q&A and I'll be feeding them throughout the night to Trevis. We'll try and get through as many as possible. And also just to let you know that the next Unspeakable Bits will be the 20th of November, the same time, 7 p.m. And registration will be going up this evening. So you'll be able to register that from this evening. So without further ado, I'll hand over now to Trevis and you.
I don't know. We might need it a little bit more ado as it gets dark. It's closing in on us pretty fast here. Hello, and welcome to this, our second last of the 2025 series, The Unspeakable Bits. As Fergal said, I'm your host for the evening, Trevis Gleason. This is the third year that we've had a series of The Unspeakable Bits, and I'd have to say that there are a good few folks that we need to thank for their continued support. I'd like to thank MS Ireland for affording us the platform to delve into these difficult topics. It's not always easy to talk about this kind of subject matter, even among family and friends who know us and who know MS. And many of the topics and subject matter were once, I suppose, considered taboo here in Ireland, and not just in Ireland, in communities around the world. So having this time and space to talk about the things many aren't comfortable hearing, let alone discussing, is an important resource for those of us who are trying to live our best lives with MS and, as we'll talk about tonight, co-occurring conditions. So a big thank you, Garm Hogwith, to MS Ireland for that. Also, it's impossible to put on these programs without they would be our expert panelists. And we've had leaders in their field from around the globe with us to delve into these unspeakable bits with us. We thank them, one and all, for their invaluable help with episodes past, present, and future. And speaking of which, all of our previous Unspeakable Bits webcasts are available on the MS Ireland YouTube channel for your viewing and your comments. We take those and we go back and we listen to them. This program will be posted 24, 48 hours after we wrap up tonight. Maybe Fergal, you could put up a link for everyone so that they can see where the previous programs are stockpiled there. And we do invite you to submit your questions tonight via the questions tab at the bottom of your screen. As Fergal mentioned, please don't use the chat function. That gets really messy at this hour in the night. Me and MS fatigue and the chat function, I would be all over the place. So your questions will be put through to us and we'll get to them as many as we can tonight. And I did mention expert panelists. Tonight is no exception. We're grateful to have Dr. Hugh Kearney of Trinity College Dublin with us tonight. Dr. Kearney, welcome and thank you for being with us.
Thanks very much. Thanks for the invitation.
And I suppose for our viewers and listeners, this is real world tonight. Dr. Kearney is on call. So it's possible that his phone will ring and he'll need to take that call because someone is in need of emergency neurological services. So if that happens, he'll probably go black for a little bit and then we'll see what we can't do to stretch. I reached out through the Irish Society of Immunology for tonight's topic, MS, and it must be said that you've done a good deal of work with MS Ireland before, Dr. Kearney. Maybe you'd give us a brief description of how immunology and neurology kind of come together and why in the hell I would have even gone that route to find you. And then maybe about your work and your research specifically tonight.
Sure. Thanks. So I guess, if we like kind of at a broad level, think about what is MS, what's going on, and why does the disease happen? So essentially, the disease itself involves the immune system. So there's a dysregulation of the immune system, and that's really at the crux of the disease itself. So studying what's happening to the immune system and why is it doing what it's doing, and why is it not behaving in another way, is a really important thing, I think, because all of the disease-modifying therapies we have at the moment, they're all licensed in some way, shape, or form to change the immune system. And, they work in different ways, but broadly, the way we might explain it in the clinic is that we're trying to calm it down, we're trying to dampen it, and the consequence of doing that is that the person with MS is less likely to experience a relapse. And that's, where studying the science of the immune system is so important. Um, my background, I suppose, originally, I did my PhD in the UK with my supervisor, who was Professor Miller. And I did my PhD on MRI, and it was really interesting, and I got a lot out of the experience, and I hope I contributed to knowledge. But then when I moved back to Ireland and I started in St. James's, what I learned about was the connection between St. James's Hospital and Trinity College Dublin. And when you're working in a centre, you kind of try and align what you're doing with what are the local strengths. And what became apparent to me very quickly is how strong Trinity are in immunology. So my first sort of foray, I suppose you could say, was a study with the clinical immunology team. And this was in St. James's. And what we were interested in was this was in 2024. So it was 2 years after the big science paper that studied the US military, showing a link between Epstein-Barr virus and causation of MS. So this intrigued me, I have to say, and it stayed with me to this day. Like I can't get away from that paper in a good way because I think it's really changed for the better how we think about this disease. So then what came into my head was, look, we have all these treatments for suppressing the immune system, but if a virus is causing, or playing a big role in the disease, why aren't we going after the virus? And so if you're going to use any medicine, you need evidence, you need proof that it's going to do what you're saying it's going to do. You can't just put it out there. So what we need, I suppose, as prescribers is we need clinical trials. So we need to have a trial in a controlled fashion to say, here's a group of people with MS, and here's drug A versus drug B, and these are the data, and this is the evidence. But if we were to test an antiviral, what we'd have to know is what's the outcome? How do we know this is having a positive effect or not? And at the moment, of course, we can run MS clinical trials, and at a local level in St. James's, we're involved in 2 trials, but they're testing drugs that are not going after the virus. And what I really was trying to get at was if the virus is causing an immune response, which we know it is, can we capture that? Can we measure that? Because the idea being, if we put in an antiviral, what we'd expect is to lower that immune response, and the follow-on would be that would be a positive thing. So what we did was, what we set about doing was we set up a blood test that we designed ourselves. And the way the blood test worked was we got people with MS attending the unit in St. James's. We also asked people with epilepsy, and we got people who don't have a neurological disease, and we took blood samples. Then what we did in the lab was we got a piece of the virus, a critical piece of Epstein-Barr virus called EBNA1, which seems to be the key driver. And we put that piece of the virus into the blood, and then we could measure the immune response, how much sort of inflammation that kicks off. And the results were interesting because what we could demonstrate was that in people with MS, there was a higher immune response than people with epilepsy or controls. So it meant that this wasn't a neurological thing generally, and that was the importance of having the epilepsy cohort. Because we didn't want to say, look, this is just a brain disease phenomenon. This is a purely MS thing. And then the next step was we looked at the treatments that the people with MS are on. And the different treatments, the mechanism of action of the treatments seemed to influence the response too. I think this was where the biology of it got very interesting. So a lot of people would be treated with medicines that would be familiar, things like ocrelizumab, which is known as Ocrevus, or ofatumumab, which is known as Kesimpta, so on, or what are called B-cell depleting therapies. And what we saw for the people on those treatments was the immune response to EBV was lower. And this is interesting because EBV is a real sneaky virus. It has its own sort of genome, and it hides in our own B cells. So in effect, by lowering or depleting B cells, our findings suggest that the knock-on effect is you're kind of taking the virus out of the mix. Now, it's not completely, so it's not, it wasn't designed as such. And really what we were trying to get at was we were measuring what's called the adaptive immune response. So there's kind of two sides to the immune system. One is the innate immune response, which is the sort of straight up, as soon as your body sees a foreign object, it goes on the attack. And those cells are kind of there to recognize and send out primers to say, look, this shouldn't be here. And once that happens, the other side of the immune system is the adaptive. So they're the B and T cells. And that's what we could measure in that blood test. So now what I'm kind of interested in going forwards is setting up a means or a way of capturing the innate immune response so we can have a sort of a complementary approach to looking at the innate and the adaptive immune response to EBV. And it's all the time at the back of my mind, I suppose, with a view towards looking at treatments that are safe, that are effective, and that don't necessarily involve immunosuppression, and ultimately, I suppose, get to the crux of what's, the leading risk factor for MS, which is EBV. And then, that circles back to that science paper. So that's, I suppose, in a nutshell.
Now, I suppose it's important for people to understand that there's obviously some sort of a genetic predisposition factor in there, because
Mm,
not everyone who gets the Epstein-Barr
mm,
virus, and it's estimated between 80 and 90% of
mm,
adults have it in their system. They get it
mm,
sometime in childhood. But there's some sort of a genetic structure that makes that happen. I use the analogy that of a game we used to play back in the 60s and the 70s. It was called Kerplunk, which was a tube with all these sticks going through it. And the sticks I equate to the genetic makeup of the person, and the marbles that go through are the genetic factor. In this case, maybe EBV, and it's only if the sticks, the genetic material is lined up, can that marble make it all the way down to the bottom, and then we get MS. It's not everybody who has that pattern, so it's a tough one. And then, of course, we know that right now in the age of anti-vaccines, if we were to come up with a vaccine that you're going to give a child, because that's when they're probably going to get EBV or get exposed to it. I can't imagine what that even looks like. But please God, someday there is a vaccine, and it sounds like we're headed down that road. Now, the other thing that I'd like to consider about the immune system, and if MS is considered sort of in that family of autoimmune disorders, um, there's a propensity, if you got one, that you're going to end up with another or more. So how is it, and what are some of the most common co-occurring autoimmune disorders that we might have after we get MS, or that people might have and then be diagnosed with MS afterward?
Yeah, I think that's a really important point. It ties in two components, like you mentioned genetics a moment ago. And just I suppose at a basic level, if we look at the biological sex differences in MS, approximately 3 women will get MS to every 1 man. That's in using, up-to-date epidemiology. And then if you look at, well, why is that the case? So women have two X chromosomes, and a lot of the genes that encode the immune system are located on the X chromosome. So if you've got two X's, you're doubling up your chances of something happening that shouldn't happen as compared to men who have one X chromosome. And then I suppose in terms of what are the conditions, it ranges and it's variable. I suppose from experience, probably one of the most common things, if you chat with people in terms of the lead in, people talk about a prodrome to MS, the decade of sort of non-specific symptoms that only in retrospect make sense. And
Mhm.
people will often say that their asthma might have flared up, their skin from eczema might have flared up, maybe their hay fever got worse, lots of these types of things. And they would be sort of common, but they're not, it's not inherently linked. It's not the case that everybody who has asthma is going to get MS or vice versa. But there are these sort of clusters. And then after the disease develops, the kind of other conditions we see that are immune related commonly would be thyroid, and not as a consequence of MS medicine, but independently, which more commonly is underactive. And again, it's a thing that's more common in women. The other sort of immune conditions are really variable because the immune system is complex. It really is. And the more you kind of think you know about it, it sort of gets away from you, and you feel the less you know. But what we would see in clinic, we would see some people who have women who have MS, but also have rheumatoid arthritis. We have patients who would have psoriatic arthritis as well as MS. We have patients with type 1 diabetes. We have patients with colitis and MS. And the list kind of goes on. Um, so there isn't a set pattern, or it's not set in stone. And equally, we have people who have MS and thankfully don't have a second immune disease. So it's not a guarantee. Um, but there is this sort of, I suppose, going back to genes, how the immune system is structured, because MS isn't what's called a monogenic. There isn't one single MS gene. It's kind of the overall makeup. And the reason it's the overall makeup is the immune system is encoded by multiple genes. So if all of the genes, so if the dice is kind of loaded by the overall makeup, then the likelihood of another immune disease increases. And I suppose that's kind of the link. And then that plays into, you know, as the person goes through life, the various environmental exposures, their immune system will respond differently than somebody who doesn't have that makeup.
And in clinic, would you be, and I suppose as I think about this, the answer to the question is sort of obvious. Some of the autoimmune conditions that you're talking about, they show up fairly acute, fairly immediate, and you have asthma as soon as you have asthma. You pretty much know you have colitis pretty quickly, etc. MS is one of those, at least it used to be a diagnosis by exclusion versus inclusion, and certainly with early detection and education of GPs, etc., that's going a lot faster.
Mm.
But would it generally be that someone has another autoimmune condition before MS, or MS and then other conditions?
It
Or is
really,
there no general?
there's no general, I don't think. Well, certainly not that I've seen. I think the only thing to say is that what can muddy the waters is that once somebody has an established diagnosis of MS, what we would often see in clinic is that any new medical problems get pinned on MS. And I think that's important to say because, if you do have a diagnosis of MS, of course MS causes certain symptoms and signs, but it's not going to do things like attack your joints or your bowel or your lungs. It will cause changes in the nervous system and the consequences of that. So it just emphasizes the need for ongoing input at a primary care or with a GP who has a more holistic view than maybe a neurologist who's very much honing in on, where's the MS at and what's the problem related, or how can we help with this? Because, when you think of other immune diseases, some of them are common. Like at the beginning we mentioned asthma, and asthma can be very well treated and managed, appropriately at GP level. And it's only, by engaging with the GP that diagnosis can be made and then managed. So I think it just speaks to the point that attending a hospital and seeing a hospital doctor doesn't rule out the need for this more holistic uh, overview of the person that the GP will have that the neurologist probably doesn't because of the training that gets,
Yeah, I want to talk about the holistic medicine a little bit more further on in the evening, certainly.
Mhm.
And as we move on to our listeners, please don't hesitate to send in your questions via the questions tab, and we will get to those as we can. I suppose another grouping of conditions which doesn't necessarily, but could affect people with MS are usually called comorbidities, which, is just one of those medical terms. It just sounds so lovely. It's a favorite of mine. Or sometimes called co-occurring conditions.
Mhm.
First off, I suppose, is there a difference between those two? Or can you, and if there is, can you describe them? Or is one just a medical term, one's a layman's term?
I think basically they're the same. And the reason that these other health conditions are described as comorbidities, it's all about the lens you look at the body with. The papers of the studies that describe, say, for example, high blood pressure as a comorbidity, that kind of study will typically be done by a neurologist who sees MS as the primary problem and high blood pressure as the comorbidity. But if you are a cardiovascular person, you'll see high blood pressure as the primary problem and MS as the comorbidity. Do you know? So
Right.
I think that's the observational component. And I suppose in the MS community, of course, there's a weighting towards the science that's developed by neuroscience and neurologists. And so in that mindset and with that view, we tend I suppose even in clinic, we're guilty of it ourselves. We would see things that we would want to identify as what we would term comorbidities. So the examples would be diabetes, high cholesterol, high blood pressure, osteoporosis. And the studies and the evidence have shown us that they are of importance. And the reason they're of importance is all of those conditions I just mentioned play a role or influence the progression of MS itself. So we know, for example, with diabetes, which is a common condition, and again, managed at primary care level usually, if it's not well managed and it's not well contained, that can play a role in the MS, you know, moving faster than it should. So
Now, let me
yeah.
stop you there because
Mm,
if I might,
mm,
when speaking of MS or of diabetes, there
mm,
are
mm,
the two types of diabetes,
mm. Sure,
and
of course, yeah.
most people will understand that type 1 diabetes is considered an autoimmune condition,
Sure.
like multiple sclerosis.
Mm,
It's the body's
mm,
immune system,
mm,
in this case, attacking the pancreas.
mm,
Um, but type 2 diabetes,
mm,
um, sometimes called adult onset
mm,
diabetes,
mm.
etc. That's that's a fairly different condition, is it not? So, are they the same as it relates to worsening of MS?
That's a very good point, actually. So, in truth, I have not seen a person with type 1 diabetes and MS. I know that that can exist in the world, but I've not seen it myself. I suppose when I say diabetes, when we're in an adult neurology clinic, what I should have clarified is I mean type 2 diabetes. Um, but even with type 2 diabetes, there is undoubtedly an immune component to it.
Mhm.
So our understanding of type 1 is it's sort of antibody driven. And as you said, those antibodies are attacking the pancreas and destroying the pancreas' ability to make insulin. In type 2 diabetes, it's kind of a resistance to insulin. But what's really interesting, and the science that's emerging is really interesting. So within adipose tissue or fat, I suppose as we would more commonly term it, there are immune cells within fat. And those immune cells are called MATES or mucosal associated inflammatory tissue cells. It's a
Sure,
bit of
we'll
a,
go with mates.
yeah, grand. And what's interesting about those cells is that they talk to each other by chemicals, but the chemicals that they talk to each other by are chemicals that drive inflammation. So there are the inflammatory chemicals are called cytokines, and there are two key players. One is called interleukin 17, and the other is called interferon gamma. And we probably know a little bit less about IL-17, but interferon gamma is important because back in the 80s, when people had, less treatment, or I think it was, sorry, probably 70s, there were less treatment options for MS, and there was a clinical trial of interferon gamma in MS, and the trial was halted very early on because what became clear very quickly was when people with MS are given interferon gamma, it drives relapses and it drives the disease to go quicker and faster and progress quicker. So it became clear that interferon gamma is toxic. And then at a cellular level, for a scientist looking down the microscope at cells in a dish, interferon gamma injures the myelin coating. So if you have, the comorbidity of diabetes, which is driven by insulin resistance, but it's associated with excess adipose tissue, and the adipose tissue is talking with these inflammatory cells, you can see how you would want to get on top of that as best as you can to reduce the accessory inflammation. And that's kind of what's underneath, that's the science underneath why we're interested in keeping an eye or doing our best to manage these so-called comorbidities. And it's just
And
choosing one example.
no, and it's a great example because in a lot of ways, some of these sort of comorbidities
Mm,
that we can talk about here can kind of come on
yeah.
because of MS if I'm more
Mm,
sedentary
mhm,
or if I feel like my metabolism has been just
mm,
shot to hell by
mm,
steroid use over the
yes.
years.
Yeah.
Um, then I'm I'm certainly heavier than I was before
mm,
MS, et
mm,
cetera. And it's more
mm,
difficult to lose that
mm,
belly fat, et cetera.
mm, mhm.
So that can then worsen the MS just because of the obesity issues.
Yeah, I guess though the exciting science again though is the class of medicines that are all over the media, which are called GLP-1 agonists or glucagon-like peptide 1 agonists. So Ozempic, I suppose, is the one that everyone knows the name
Mhm.
of. And these drugs were designed for type 2 diabetes. And then it became clear that weight loss is a phenomenon associated with that. But the most up-to-date science shows it's more than simply weight loss. These drugs, by their metabolic effect, are anti-inflammatory. And that's really interesting because the Swedes, who are always kind of leaders in terms of public health, and the reason being in Scandinavia, you're born and you're given a health number and you carry that health number through your life. So it means that for scientists and doctors who want to study a disease, you can see the cohort of people and you can see all the life factors associated, which we can't do in Ireland. Um, and what they showed was that for people who start Ozempic or similar medications, the incidence of MS goes down, which is really interesting because we know early life excess weight or obesity is a risk factor. It wasn't always entirely clear why. It was thought maybe vitamin D played a role, but I think now it's becoming clear that perhaps it's the inflammatory or pro-inflammatory effect. It's kind of setting up this environment where inflammation is sort of more widespread in the body. And now I suppose that we've begun to think about medications and thinking about weight as a medical rather than a sort of a judgmental thing. We can then, say that, look, we do have evidence that these meds can drop body weight, but the science is pushing us in a direction to say that it goes beyond losing body weight and they are anti-inflammatory. What we don't know, though, and we don't have evidence for, is whether these type of medications influence the outcome for MS itself. Like, could they be disease modifying? And we don't know, is the honest answer. I mean, what we get asked about in clinic for, myself and the nurses I work with, many people might get access to one of these type of meds through their GP, and their first question is it safe? And we would say emphatically yes. And then depending on what's, level of information is asked of us, we can go into the science of it a bit, depending on what the person wants to know. But ultimately, their primary concern is, will this harm my MS or will it make it worse? And I suppose based on what we were just chatting about, the answer to that is no. It possibly theoretically could help. We can't say it will, but it certainly won't harm it. And that, I guess, is different to a few years back, where the advice for body weight would have been, oh, diet and exercise, which
Mhm.
is not, you know, like as you just described, if your mobility is impacted, telling somebody to do those things, it's, that I think you can, yeah.
Yeah, exactly. Now you opened a door there that I'm going to go through.
Mhm,
Um, and that has to do with the well-informed patient.
mhm,
Uh, you'd mentioned, how much more the patient wants to know, or
mhm,
perhaps if they're using med and can understand medical terms,
mhm.
are they getting more? I'm a big advocate of being an informed.
Yeah.
Sometimes I put it in inverted commas as a professional patient, and
Mhm,
going in there because if you can understand and use some medical terms appropriately in conversation, I feel like the information that you get back is at a whole other level. You can't just throw out terms, obviously, and not be able to catch them back.
mhm.
So that's important. But I have heard from other people, particularly here in Ireland, that kind of discourse can sometimes not be appreciated by the medical professionals. I've seen it myself with someone I was helping through an oncology department, and used some medical terms and was sort of called out for doing so.
Mhm.
So I'm wondering, in general, at the clinic that you are a part of, um, how responsive are you to and this isn't just coming in with
Mhm.
Dr. Google notes
Mhm.
either. I mean, this is somebody
Mhm.
who's really engaged in
Mhm.
trying to live their best
Mhm.
life.
Yeah. Um, you know, at the end of the day, language is a way of expressing or communicating a thought. And whether you're going to reach for your everyday, day-to-day words and language, or you want to use scientific or medical language, I don't think it, I don't mean it doesn't matter, but it's not the main point. The main point is, has the person been able to communicate effectively what is it they want to know or what is it they want out of that consultation? And if from their point of view they feel using medical or scientific language gets that point across clear or the question, perfect, that's not a problem. Equally, if somebody doesn't feel they have that within, that's not a problem either. We would, I suppose, ultimately the goal, in terms of treatment is we want each person coming to the clinic to be able to feel that they're in control, they have autonomy, and they are living to the best extent possible as they would have before the MS came on. And I suppose that's kind of, the philosophy that we would try to adopt. And that's, I suppose, what informs the makeup of our clinic. So we've nurses, we're very lucky to have an MS physio, an MS occupational therapist, and a social worker. So, when somebody presents with a problem, the mindset, even with medical training, it isn't that like tablets are always going to be the answer. And maybe the smarter answer is going to come from one of the other medical professionals. So that's, I suppose, where the language and the communication of the problem is critical because, if we can't understand what it is the person's driving at, then we don't know how to help. But
Right.
as long as there's a sort of a level of understanding, and whatever way that's achieved, is to me, you know,
That's that. Thank you very much. That helps a lot. We're getting a question has to do with the weight loss meds you're talking
mm,
about.
mm,
Is there any counterindication between the two of them? There's me using a medical term. The question actually says, will they fight against each other? But is there any reason to think that of that class of
mm,
weight loss medication that you're speaking of,
mm.
that those shouldn't be used with any of the DMTs?
There's none that spring to mind. And you know what the weight loss drugs are primarily doing, are they're having a metabolic effect.
Mhm.
We know within immunology, where we began this evening, there is a field called immunometabolism. So within immunometabolism, there are MS drugs. In fact, there's one MS drug that is an immunometabolic treatment, which is dimethyl fumarate, or Tecfidera is the other name it goes by. What that drug does is that's probably the only drug we have as an MS disease modifying therapy that changes the metabolism of immune cells, which is different to most of the other ones, which either sort of walls off the immune cells or blocks them or it gets rid of them in some shape or form. So if we're happy to use metabolism to our advantage to treat MS, then if we're using weight loss drugs in a similar fashion, they're targeting metabolism, but to my mind in a good way, because by decreasing or dialing back, intake and glucose, what you're kind of doing is you're actually dialing back on inflammation, and it's not in an immunosuppressive form. So irrespective of the MS disease modifying therapy, there wouldn't be a crossover. But it's very understandable because it's something we do get asked all the time. Because at present, those weight loss drugs only come in injection form. And so absolutely understandably, you would think, is it a biological med? Will it interact? Will it cross over? Will it immunosuppress me even more than I already
Mhm.
am? Or something like that. And I think just trying to have a clear discussion about some of the science of it hopefully helps to ease those concerns and to emphasize it is important that if that's an appropriate treatment to continue with it. Um, I think then, into the future, I think if sufficient people who do have MS and are using these meds to treat obesity, then we'll probably get what are, sort of real world evidence or observational data to be able to tell us how do these drugs influence the course of MS. And that's what we don't know at the moment. And we suspect they will be helpful, but we can't sort of, we don't have trial evidence to stand over a statement like that. And
And I
that's where,
suppose it'll take anecdotal evidence before anyone which is, and right now
Yeah,
the availability of those medications are
yeah,
very difficult. So
absolutely. It has to do with the manufacturer, but the good news, and I suppose I'm an eternal optimist, there's an oral formulation of these drugs coming out, and that oral one is said to be more potent than the injectable forms. And a part of the rate limiting step of production is the temperature and the manufacture, whereas when it will be produced in tablet form, then that will bypass those sort of bottlenecks. So it's not a forever scenario that they're going to be injectable. And I think probably in tablet form, like many drugs, once they become available as tablets, it does make the accessibility greater. And I think there's less of a psychological component to taking a pill compared to injecting yourself. And that hopefully will help to destigmatize the use of these medicines.
yeah. Now, one last bit on these co-occurring
Sure.
comorbidities is there anything that we can do
Mm,
to avoid, I don't want to say catching them, but acquiring them?
yeah.
If it's sedentary lifestyle, but
Mm,
there's not a lot that we can do about
mm,
that.
mm,
For example, when it comes
yeah.
to cardiovascular disease or obesity.
Yeah. Yeah. I think that's a really important point because it's, um, I guess again, it comes back to autonomy and ownership and trying to take control of the situation yourself and do what's the best you can do. So the first thing that comes to my mind, and purely because it was presented at ECTRIMS, which is the European Conference for MS, just at the beginning of this month, there was a nice US study, and it was a study on diet. And what it showed was that the amount of ultra-processed foods that people with MS eat, if they eat more ultra-processed foods, it results in greater progression of MS. So that's one thing that now, because what we often get asked in clinic is, what should I eat? What can I eat? And, our generic answer to date has been eat a balanced diet or have, try to have a healthy diet or whatever that means. Whereas now we can sort of say with that scientific evidence, as far as possible to avoid ultra processed foods. Now, that isn't easy, and I would freely accept that is not an easy thing to do, because we're bombarded with them everywhere we look, in every shop and every supermarket and whatever. But even to just have that awareness, and if you do feel like you really want to get into this, there is what's called the Novak classification of foods, which is how processed a food is. And in general terms, you know, the less it looks like food, the more processed it is.
The
So
Novak principle, you said?
classification, yeah.
Novak classification. I'm sure that everyone's going to Google that right now.
So that's one thing that you that we do have control over what we put into our mouths for most of us. So, but then even though and with that knowledge, it's not that you can flip a switch and say I'll never touch a processed food again. Of course we all will. It's part of life, but it's just trying to have mindfulness or awareness that if there are choices in your shop, in your supermarket, whatever, to maybe have an awareness that the less processed I'm eating, the better I will be. Do you know?
Mhm.
I think then in terms of so that's one. I suppose that's the first thing that comes to my mind. The other things then go back to mentioning the GP again, and I think I've always had in my head that trying to prevent or pick up early is a key thing. So the GP has a wonderful role in terms of public health and picking up things before they become a big problem. So getting your blood pressure checked, it might seem like a small thing, but actually we know that blood pressure is really important in MS. And the reason is when people when the MS changes for someone from sort of the earlier inflammatory relapsing phase to a more progressive phase, the lesions begin to form or grow in what are called the watershed areas of the brain. So these are the brain has big blood vessels going up, and they sort of map out different areas. So this blood vessel supplies the front and the side and the back and so on. But there are gray zones in between the supply where it's not one artery, it's not the other, and it's kind of no man's land. And they're the parts in the brain where the plaques begin to form as the disease progresses. But because if you've high blood pressure, those tiny little blood vessels are the ones that are going to get damaged. And so even though it seems like a trivial thing to have your blood pressure checked, but getting it checked and knowing it's high and then getting it treated, you're going to then, in the long term, reduce the amount of uh, harm from excess blood pressure, harming those tiny little blood vessels that are vulnerable to injure when there's excess pressure. The other kind of areas in similar vein are cholesterol. Um, Many people who are watching might be aware of the STAT trial led by Jeremy Chataway, testing simvastatin. The phase 3 trial is out, and it proved to be negative in terms of progression. But what was interesting was when you look rather than that endpoint, are what are the cardiovascular outcomes of the people who took part in the trial? And they were reduced. And I think that's important because from an epidemiological perspective, people with MS have a slightly increased risk for heart disease and stroke. So then looking at cardiovascular risk factors, again with your GP, which is a simple blood test to get your cholesterol checked, it becomes all the more important, to know that it's high and to take action if that's needed or if it's appropriate. And these are the kind of things that we might do in clinic or encourage somebody to get to their GP and have a look at. And I suppose the last thing in terms of that regard is vitamin D, which can be tested for, and that relates to bone health. You know, because we know that bone health also plays a role in terms of the overall trajectory of the disease. So in terms of for women, if they're postmenopausal, looking at getting a DEXA scan, knowing your vitamin D level, and if there are early changes on the DEXA scan, intervening and starting medicines, calcium or whatever is appropriate. But, you know, treating one of these comorbidities, if we use that term, won't, it's not that you'll all of a sudden feel different, but it's all about the long game. We're talking over the decades, not the days and weeks. But by managing and staying on top of all of these things or picking them up early, it definitely does make a difference.
Excuse me, you brought something to mind there when you mentioned the transition between inflammatory disease and
Mm,
post-inflammatory disease.
mm,
And you talked about the Ozempics of the world
mm,
and inflammation.
mhm,
Theoretically, and I know that we're only talking theoretically now because
mhm,
we haven't even got the anecdotal evidence.
mhm,
Your thought process then on whether a drug like that seems to help
mm,
modulate inflammation,
mhm.
would that have the same impact on would it perhaps have the same impact on MS once it passes through and it becomes a non-inflammatory disease?
Well, it's already been looked at in another brain disease, in Parkinson's.
Mhm.
So there have been trials of tirzepatide, which is one of these meds, weight loss meds, and the early trials seem to have it's not a significant impact, but they do impact the progression of Parkinson's disease. So then I suppose with the evidence that these medications are anti-inflammatory, it stands to reason that it would be worth looking at, given that they're not going to cause harm. You know,
Mhm.
that's the starting point for even considering the evidence for a trial is, are we going to harm the person or is this going to prove to be good? I think there are opportunities for medicines such as that, which wouldn't be considered conventional MS disease modifying therapies. And one such forum is a clinical trial called the Octopus trial, which I think, many people will be aware of or have heard of. And this is what's called a platform trial, where it's a multi-arm, multi-stage trial. So in most clinical trials, the usual paradigm is you've the drug you want to test and a dummy pill, and you
Mhm.
run it out, and the trial runs over 4 or 5 years. And if the drug doesn't work, you're back to square one. So to sort of counter this, what the guys in London, led by Professor Chataway, have done is they're going to test multiple drugs at the same time, have an interval analysis by measuring the brain scan, and the drug that's not performing, the people will shift over to the two that are. And then there will be an analysis of clinical progression, and that's the end of the first stage. But then it rolls again and another stage, and more drugs can be added in, and then you go through those stages and phases. And this was all modeled on a trial called the Stampede trial, which was it lasted 14 years to give you a sense of it. And what it was to do was, it was to do to do with refinement of the treatment of prostate cancer. And each time the trial went through another phase and stage, the knowledge just grew. And that meant that the treatment and the outcomes for men with prostate cancer got better. And each iteration led to little improvements. So it wasn't that there was ever suddenly a radical jump. But if we then think about that from an MS perspective, because progressive MS takes a long time and it's not something that happens overnight, then if we see even little gains over the period of a trial going that's going to run for like a decade plus, by the end of that trial, we would be hopefully in a position to understand more about the disease, to understand more about what meds might help, and then to understand what's the best combination of meds that it might maybe be, which a regular trial wouldn't allow for. So who knows, maybe it is a weight loss drug plus a disease modifying therapy or, some combination thereof. And these are kind of the exciting questions that trials like Octopus will enable us to kind of explore.
You've segued for me perfectly because I'd like to talk about the is it safe parts of the drugs, etc. But more importantly, long-term side effects. We talked about a little bit before we started here. I had a long, well, a year and a half worth of 6 3-day infusions, so a fifth of my life at that point. I was getting a steroid infusion because my MS was that bad at the time, and that was all that we could really do. Then I developed avascular necrosis, which is a death of the blood vessels and the death of the bone in long bones. It was my hip. Now that, that damage is done, it was replaced, but now I'm 18 years past that. So now it's time for, not that MS didn't cause me needing a second hip replacement. MS didn't cause me needing the first one. However, treatment for MS probably did. So what are some of the long-term side effects that are possible that we might be looking at for a person who's on medications, be it DMTs or possibly symptom management medications, etc. What could we be looking at? And they could be symptomatic like that, or actual maladies that develop because of them.
Yeah, I guess what we would always say to clinic and try as best we can be straight with people and say there is no perfect drug, there is no perfect medicine, and it's always a balance. It's always what is the good you're trying to achieve with the medicine versus what's the downside. So when, for example, we're discussing medicine with somebody who's newly diagnosed with MS, which is it's a very difficult time, we have to be straight with them and say, look, this medicine, the advantage or the plus is you were less likely to experience relapses. But, and the people all say, oh, there's also but, and there is, that is the truth. If, for example, we use, say, for example, a B cell depleting medicine, then we're taking away a cell from the immune system, going back to the opening this evening in the immune system. So if we take away a cell that makes antibodies, that is a positive in terms of we understand that those B cells play a critical role in driving the MS disease. So we know, looking down the microscope at brain samples of people who passed away of MS, B cells are latched onto the lining of the brain. So we know they're baddies. We want to get rid of them. But it is at a cost, and we do accept that. And the cost is infection. And it's not surprising. So if you take away a part of the immune system, then infection raises its head. And that's the balance. Like the harder you go after the immune system, the more infection you're going to get. And it's trying to get the sweet spot in between the two.
Now, those B cell therapies, those are the ones that, perfect real world example. A lot of people who were on those medications didn't show any form of immunity when they received the COVID jabs.
So initially that was thought to be the case, and now things have developed. So there are two sides to a response to a vaccine. There's the adaptive or B cell driven response, which is the easily measured one because you can measure antibody titers. And there's also a T cell response. So what has been shown is after the in original COVID vaccines, there were two jabs and then a booster.
Mhm.
After the booster, for people on B cell depleting meds, the T cell response was equivalent to a person not on B cell depletion.
Hmm.
So, in other words, because our immune system, again, just because it's so complex, but it's also clever, it's a smart thing. The T cells pick up the load that the B cells have dropped, and they produce the response. And the outcome is equivalent. So early in the pandemic, people on B cell depletion, it was a significant concern. But we can now allay people's fears and say, because your T cells will do this and we can measure the T cell response, it's okay. And then it speaks to, going back to some of our earlier points about managing comorbidities, and infection is a part of that. So sticking with the vaccination schedule is really important.
Right. And it's not something, I suppose at the very beginning, everyone was reacting immediately because
Mm,
we were all trying to, it was a
yeah,
very
yeah,
emergent
yeah,
situation. So
yeah,
I
yeah.
was unaware of the T cell
Mm.
response there. So that's good. Now, we don't want this to be all like doom and gloom
Yeah, 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 yeah,
here. And we had talked about the multidisciplinary
yeah.
aspect of this
Mm.
and approaching it so that maybe we can reduce the risk of some of these comorbidities
Yeah.
or these co-occurring conditions.
Mm.
So you talked about in clinic there that you've got
Mm.
a multidisciplinary team. You're
Mm.
bringing the GP into that as well.
Mm. Mm.
Um, how maybe just in a couple of minutes, how is it that we can access a multidisciplinary team? We all know that there's shortages
Mm.
of just about every sort of medical
Mm.
provider
Mm.
that there is, et cetera. But what would be an ideal medical interdisciplinary team right now for if I came to you and said, okay, I want to avoid as many comorbidities as
Mm.
possible. What would that
Mhm.
look like?
Um, so last year, myself and some of my colleagues in Trinity, we published what's called a systematic review. And what we did in that systematic review is we pooled all of the evidence for every healthcare professional involved in MS. And
Hmm.
it allowed us in the systematic review to say, what is the evidence for each person? And the reason we did this was there was a team in London led by Professor Giovannoni, who many people would be aware of in the MS community. And he and his group had written a paper called the MS Unit. And what they did in that paper was they spelled out, to their mind, what is the ideal MS unit? What would it look like? Who would be there? How would it operate? And so on. But what caught our eye was we looked at the references in the paper. In a scientific paper, you'll have a series of other papers that you're backing up your statements with. And as we looked through them, they were all mostly relating to stroke. And we thought that's curious. It's of course it's nice to see an MS unit being advocated for, but if the evidence is relating to a different brain disease, how much can you stand over the statements being made? And that's what led us to write what we called a systematic review, where essentially we pulled every paper we could. So we thought of the people in the MS unit, the physiotherapist, the occupational therapist, the psychiatrist, the dietitian, so on and so on. So we'd like a long list. And we were able to sort of compile an evidence base. And the answer is there is clear scientific evidence for each and every actor or person. The trouble is, and as you rightly mentioned, is access, and this is, something that I think, from an MS Ireland perspective, we know about the campaign for access to physio, and MS Ireland have been in the Dáil, in a fantastic way, advocating, campaigning for the need for physio. So if we think about the physiotherapist as one healthcare professional, physio is, I think it's so important, and it's important right throughout the spectrum of the disease, from the very beginning to people maybe at a more advanced stage of the disease. And the reason is there's always something that can be done. Um, and if we think of somebody who's just been diagnosed, they might ask us questions like, can I still go to the gym? Can I run? Can I cycle? What can I do? Or what's good for me? What's bad for me? And, we will give some advice, but then we will say, look, our physio is trained, is a specialist physiotherapist, and they really appreciate being able to interact with somebody who's training. Then maybe if the disease changes and people are experiencing spasms or cramps, again, rather than reaching for meds straight off, physio can sometimes alleviate some spasms and cramps. Or if somebody has quite advanced or progressive MS and there's more marked spasticity, you can do things like passive stretching, or
Mhm.
you could do that in combination with Botox. So right, right from sort of one side of the disease to the other, physiotherapy has a clear role. And what we saw in our study was that the evidence base is strong. And then if you go kind of beyond that in terms of treating the symptoms, we know that exercise, and it doesn't mean excess like marathon running or something crazy. Exercise is the only treatment we have right now that helps to remyelinate. So we have evidence that physical exercise, which can be, it can be chair yoga, it can be walking, it can be whatever, gardening, it doesn't matter. But some form of movement of the body is a way that the nerves restore function, and it kind of speaks to the need again for a multidisciplinary approach because without a physio, us saying, "Oh, go exercise," I don't think that's as credible as when it comes from a physio who that's their life, that's their and then you could think about any of the other people in the same vein, and they're of equal importance. Like if if you found a wealthy donor and they wanted to invest in this, you would say, look, each and every neurology site or center should ideally have access to all of these things,
Mhm.
and it shouldn't be kind of a luxury or an add-on. It's critical, I would say.
All right. Listen, our time is going at pace here tonight, and we've covered a lot. As always, there's so much more that begs discussion. Um, have you any final thoughts on the unwelcome second or third, or I suppose that might come alongside after before MS for our listeners?
I think, it's probably a hard thing to sort of sum it
Wrap up
up.
a whole,
Yeah. I
yeah.
I think the only thing that I would say is that research is moving apace, and that is of importance because in the past research in MS focused on relapses and relapses alone. And now I think the scientific community as a whole, and I read a review paper today about the new diagnostic criteria.
Right.
And in that paper published in MS Journal, the author, Jeffrey Cohn, said that this split between relapsing and progressive MS is arbitrary. That was the word he used. So now we're beginning to think of the disease as the disease and not try and split it out. And that means that it'll form the way we think about treatment and how we research the disease, what's driving it. And I guess that means that whilst treatments are probably weighted towards people with relapses at the moment, as time goes by and knowledge develops, this will change. And I think that's really optimistic. There's a lot of hope for the future.
No, that's really important. And I thank you very much. As always, our time has quickly come to an end, and there's so much more to discuss. But with with MS, sometimes we need to know when to say when. So I thank you, Dr. Kearney, for your time and your talent tonight. We really do appreciate it. And don't forget to mark your diaries. Our next episode, we're going to talk about becoming invisible because of MS on the 20th of November, again at 7 o'clock. So mark those calendars. That'll go up soon. And until then, I suppose I'm Trevis L Gleason, wishing you and your family the best of health. So cheers, and back to you, Fergal.
And just to remind people that I put up in the chat and it'll be up on our social media tomorrow, the registration for that next webinar. And also I'll be putting up on our YouTube channel and on our links on our socials tomorrow for this. We recorded this episode, so that'll go up tomorrow as well. And finally, just want to thank Dr. Hugh Kearney again for really great talk tonight and for giving us his time. Fantastic. And as usual, Trevis, for all the work that you do for this webinar. So take care, everybody, and thanks again. Take care. Bye.
Cheers.